Medical education has long compartmentalized the human body. For decades, practitioners were trained in lecture halls like this one to view the eye as an isolated system. If a patient presented with ocular inflammation, the clinical instinct was to treat the eye alone. But clinical practice has evolved. The anatomical reality is that the eye is deeply integrated into the body's broader systemic networks. In many cases, a severe ocular flare-up is the earliest clinical warning of respiratory, gastrointestinal, or genetic emergencies. Often, it is the only outward symptom. To accurately diagnose these patients, we have to trace the physiological pathways of small vessel vasculitis, navigate the shared corridors of mucosal immunology, and identify specific metabolic mutations. We must distinguish between localized irritation and highly destructive emergencies, like necrotizing scleritis, where the very tissue of the eye is melting away. Treating that specific symptom without investigating what is driving it systemically misses the underlying pathology. In many of these conditions, failure to address the systemic driver is fatal. The physiological bridge between the eye and distant organs like the lung or the gut relies on a shared immunological framework, the body's mucosal lymphoid tissues. Consider gut dysbiosis. A severe imbalance of microbial flora in the gastrointestinal tract triggers a localized inflammatory response. If this persists, the tight junctions of the blood-intestinal barrier break apart. Once breached, inflammatory cytokines and primed T cells spill directly into the underlying vasculature. These rogue immune cells are quickly swept away from the gastrointestinal tract and trafficked through the systemic circulation. When they eventually reach the eye, a phenomenon called molecular mimicry occurs. The eye possesses its own eye-associated lymphoid tissue. The systemically trafficked T cells mistake this local ocular tissue for the original gut antigen. They lock on, triggering an aggressive autoimmune attack against the eye itself. This same immunological corridor explains why conditions like allergic asthma or viral upper respiratory infections frequently present with acute ocular involvement. The systemic traffic flows directly to the eye. Administering topical steroids will suppress the immediate ocular inflammation, but if the distant mucosal dysbiosis driving the immune trafficking is left untreated, the eye will inevitably relapse. This systemic to ocular mapping becomes even more vital when triaging acute vasculitic emergencies, such as granulomatosis with polyangiitis or GPA. GPA presents a distinct clinical triad: small vessel vasculitis, necrotizing granulomas of the upper and lower respiratory tracts, and glomerulonephritis. In the eye, the primary manifestation of this disease is painful proptosis. Nearly 50% of patients with GPA develop intense orbital inflammation that physically pushes the globe forward. The second, highly destructive ocular marker for GPA is necrotizing scleritis, often paired with peripheral ulcerative keratitis, or PUC. Seeing a patient with PUC and concurrent respiratory symptoms mandates an immediate referral for rheumatological intervention. We find a very different diagnostic map when we look at the gastrointestinal tract, specifically concerning inflammatory bowel disease like Crohn's or ulcerative colitis. There is a common clinical misconception regarding uveitis, the HLA-B27 gene, and IBD. While anterior uveitis is heavily linked to patients with inflammatory bowel disease, an actual uveitis flare-up is independent of the bowel's inflammatory state. You can see active uveitis while the gut is in total remission. This chart shows the high-fidelity ocular biomarker for active bowel disease, episcleritis. When you track the incidence of episcleritis against bowel inflammation over time, the two move in synchronized lockstep. Therefore, differentiating between an inflamed sclera and an inflamed episclera dictates exactly where you route your patient, to emergency rheumatology or to gastroenterology. This predictive power extends into hereditary and genetic markers, notably the colon cancer predisposition condition known as familial adenomatous polyposis, and its variant, Gardner syndrome. The earliest clinical indicator of Gardner syndrome does not appear in the colon. It presents on the retina, long before any intestinal polyps ever form. It manifests as bilateral multifocal CHRPE. Unlike typical benign lesions, these take on a highly specific bear track or pisiform, fish-like morphology. We see another definitive anatomical finding in hepatolenticular degeneration, commonly known as Wilson's disease. Here, a genetic flaw disrupts normal copper metabolism. The excess copper systematically deposits into the tissues, settling very specifically at the level of Descemet's membrane in the cornea to form a Kaiser-Fleischer ring. Finding a true Kaiser-Fleischer ring is a critical triage moment. It is present in 95% of patients with neurological Wilson's disease. Its presence demands an immediate central nervous system evaluation. In cystic fibrosis, a mutation in the CFTR gene impairs ion transport, causing thick mucosal secretions that eventually lead to secondary pancreatic insufficiency. That pancreatic failure severely limits the absorption of vitamin A in the gut. Clinically, this malabsorption cascades directly to the eye, presenting as xerophthalmia, extreme dry eye, and night blindness. Even highly specialized infectious pathogens leave identifiable markers. Consider the rare CNS involvement in Whipple's disease. The bacterium responsible causes a pathognomonic visual sign, oculomasticatory myarrhythmia. The patient's eyes will oscillate in a divergent and convergent rhythm that perfectly synchronizes with the mechanical action of their chewing muscles. Whether it is a metabolic error, an inherited genetic trait, or a specialized pathogen, these conditions result in specific, observable physical changes within ocular tissues. The eye is never an isolated, immune-privileged silo. Mucosal barrier breaches, systemic vasculitic cascades, and precise metabolic mutations all present themselves within ocular anatomy. Practitioners must utilize a rigid clinical triage matrix when encountering these specific symptoms. Painful proptosis directs us to rheumatology. Episcleritis points directly to gastroenterology. And finding multifocal CHRPE demands an oncology referral. Relying on a purely topical approach when faced with these indicators treats the symptoms while ignoring the cause. Correctly identifying a local inflammation as the result of a systemic pathology enables the medical team to intervene before a respiratory or gastrointestinal crisis becomes fatal.